5 things to know about ICP. It's the most commonly asked questions that we hear a lot of the time. So firstly, the diagnosis of ICP is a bile acid level above 10. Usually when your physician gets a bile acid level on you, they're looking at something called a total bile acid test, but there's also fractionated. I don't know if anybody has personal experience with this. For me, I think it was through Mayo Clinic, so I didn't know of the one through Quest Labs, but apparently Quest also has fractionated and total. And the thing to remember about this is if the diagnosis is at a level of 10 or the level of the upper limit, since any bile acids in the blood is considered abnormal, that it's considered diagnosable for ICP. So if on a fractionated test, you have levels of 6.8 or 7.8 or 8.8, you must still be diagnosed. There is some controversy on fasting before testing. It has been shown that if you fast prior to these testing, that it might miss some mild cases because the bile acids tend to be lower directly before fasting and getting the blood test done. So theoretically, if you were to fast for 6 or 8 hours or even up to 12, you probably would be missed if you had a mild case of ICP. So it's better, at least I was not told to fast for my test. They just said to eat regularly and tested me then. And then the second thing to remember is the risk of stillbirth is not the same in all ICP pregnancies. This doesn't apply to other risk factors, but stillbirth is the one that we hear the most about. Obviously, it is the most severe risk. The risk comes with levels over 100. So if your total bile acids are over 100, the risk of stillbirth is going to increase. So if you look at the level of elevation of bile acids in the blood, you start seeing accumulation of risks. When you hit about 40, that's where you're going to see some preterm labor risks. You're going to see the infant be born at an earlier stage. They might have more trouble with their lungs if they're a little bit on the younger side. But the stillbirth risk, where the baby might be born without, not breathing, could be increasing when the bile acids are over 100. So if the levels are less than 40, the stillbirth risk is 0.13%. That's about the same as the general population. Between 40 and 99, you see the stillbirth risk rise to 0.28, which is still around the same as the population. But when you get over 100, the stillbirth risk is going to be 3.44%. And I think I read recently that the higher it gets, if you hit numbers of 500, 800, the stillbirth risk is going to rise accordingly, but they don't have enough data on that yet. So I don't know if they have exact numbers.
Yeah, and I'll just jump in. Can I jump in really quick on that? Just because I know we get a lot of questions in the group on that study and kind of where that came from. So those numbers are actually from a study that has become the gold standard. So a lot of the old numbers on stillbirth risk came from studies that grouped all pregnancies together. And so that was actually a study where they looked at all the literature that had been published, took all of those small little case reports, combined them together. It's a worldwide data set from the UK, from a lot of the United States researchers, and they put it all together into this pool of 5,500 ICP women. And they were finally able to say, where does that risk lie? And it really came out that that risk is really for the groups over 100, that those people really need aggressive management. And that's not to say that we ignore the lower levels, because obviously they need, well, as we'll go through later, properly timed delivery. But the good thing to note was, it was reassuring always for me in my pregnancies when I had my numbers in the 40s, that it probably wasn't as high as those earlier studies that had come out that were more based computer models and such. So that is kind of where those numbers came from. And those are kind of the gold standard. And the other thing to note with those is they hold really until kind of that 38th week. But the reason that most cholestasis literature, and at least in the United States, the UK is always different, we are US based, says that you should not go in past 39 weeks is just because there were not enough pregnancies that went further. So really that data holds till kind of that 38th week. After that, there's kind of not a lot of data out there. So all right, perfect.
And like I said before, we know that the risks of stillbirth and preterm delivery will follow the levels of the bile acids. So if you're somebody that has a bile acid level of 6.8, it's going to be significantly less than somebody with 668. It's reasonable to ask for repeat levels. Usually, it depends on the OB-GYN. I've been to 3 for 3 of my pregnancies, ironically, so it was 3 different times, and 1 did do repeat levels. The second one, not as much, and the third, I think I only had it done by a GI specialist after delivery, so I'm not sure if there's I haven't seen anything concise necessarily about repeat levels, but it would be reasonable as a patient to ask for this. The third point is delivery timing is based on your highest ever bile acid levels. So like Laura was saying, generally speaking, it's not a good idea to go beyond 38 weeks and 6 days or so. When you hit the 39 weeks, it gets kind of dicey. So for bile acids over 100, where you start worrying about that stillbirth risk, you like to deliver between, I mean, I've seen even as low, they told me 34 weeks, but it looks like the guideline here says 36 weeks and 7 days. If you have bile acids between 40 and 99, you're going to be looking at 36 weeks, maybe 6 days to 39 weeks, 6 days. And then they would consider if you had significant itchiness, if your levels were rising, if the baby wasn't moving as much in some of the testing that they'd perform, like the physical profiles, then you could consider an earlier delivery instead of a later delivery. And then bile acids between 10 and 40, you'd be looking at more of a normal delivery, probably at 38 weeks or so. But again, that would depend on if your levels increased, if you had more other problems or complications during the pregnancy. I think preeclampsia is more associated with ICP. So if you're somebody with preeclampsia plus ICP, that would also alter the numbers there too. And then earlier delivery can be considered at around 34 weeks in some cases. So delivery timing occurs on the highest bile acid level ever. So if you start off with a level of 8 and then it increased to 90 and then it went down to 40 and it went back up to 120, that 120 level would put you at the higher profile risk. And that's the one that they would use to determine when you should deliver. And there aren't great studies right now to show that if the levels are necessarily lowered with ursodiol, if they even do lower with urso, that the risk to the fetus themselves are lowered. In theory, it should be decreasing these risks, but it hasn't been proven in controlled trials. So generally speaking, if you plan the delivery between 36 weeks and 37 weeks, up to 6 days or so, steroid administration should be given to prevent respiratory distress in the infant. The infant's a little on the young side, and you don't want them to end up with a long NICU admission and give their lungs a chance to develop. So no ICP pregnancy should go past 39 weeks. And as Laura was saying, that's primarily because the data kind of ends there. But if you're somebody with levels between 40 and 99 or over 100, it shouldn't be near 39 weeks anyway. So ursodiol is still the recommended treatment in the United States, but there's actually a lot of controversy around ursodiol. Ursodiol itself, it's a bile acid that occurs naturally in the blood. You get dosing between 2 to 3 times a day. I think it can go up to 5. I think I was taking 5 times a day, depending on the bile acid level. And in theory, it should be replacing the more toxic bile acids and allowing them to excrete as less toxic. In other studies, it's been shown to protect the fetal heart cells from changes induced by bile acids, preventing long-term changes to the placenta, and correcting the delivery to transport the bile acids away from the fetus. So this should help the fetus, but again, this is something that, depending on the study you read, they don't always say that this is a guarantee. So does it necessarily prevent stillbirths? The gold standard is still ursodiol, but it's not shown that ursodiol necessarily lowers bile acids or prevented stillbirth risk. There's a decrease in the preterm birth risk with ursodiol, but not necessarily with stillbirth. So it doesn't really affect those delivery numbers. Even if you do decrease your levels in ursodiol, we're still going to go with the highest ever level you had. So if the bile acids are lower in ursodiol, the risk still could be lower in theory, but it hasn't been shown across the studies. Something to consider is that there isn't a large number of ICP women and babies studied. I think Laura mentioned 5,500, and most of the studies I've seen are either case reports or they're usually under 100 women participants. So it's hard to definitely say whether or not the ursodiol does lower the risk. It's something that they will still prescribe you, and it's something that you can think might help with the preterm birth risk, but that's the only thing that it's been shown to necessarily lower. So for number 5, the ICP diagnosis can be the first sign of an underlying liver disorder, and there's many of these, unfortunately. It can be linked with gallbladder diseases, gallstones and inflammation, cholangitis, think hepatitis, pancreatitis, non-alcoholic fatty liver disease, cirrhosis. The most common is gallstones. And I think I read a study somewhere that showed that between 60 and 80% of ICP women tend to lose their gallbladders about 5 years after the last delivery. So removal of the gallbladder, a lot of people think, will that help with ICP? Will it prevent the next pregnancy? But it doesn't. The problem tends to be more in the liver, not necessarily the gallbladder by itself. There's a link to hypothyroidism in women and other autoimmune disorders, and I think cardiovascular disease, a very slight link there as well. ICP is thought to have a genetic cause, and they think some of the genes that cause ICP cause these other issues as well. ICP tends to be a little more prevalent in Scandinavian women, Hispanic women, I think Southeast Asian women, but it can affect all women. So as far as the underlying liver disorders, it could be autoimmune hepatitis. There's something called alpha-1 antitrypsin deficiency that affects both the lung and the liver at the same time. It's something that usually women get in their 20s and 30s, even up to their 40s. There's cyclic itching syndromes, primary biliary sclerosis, primary sclerosing cholangitis, and of course, hepatitis C. So generally speaking, if somebody has an underlying liver disorder, they're more likely to have higher levels. And if it's a genetic problem, you're going to see multiple family members with gallbladder issues or ICP diagnoses. So as far as after pregnancy, do you necessarily need to worry about ICP, or is this just a pregnancy issue? So the levels should be measured at around 6 weeks postpartum when you go in for your normal appointment. If the levels are still abnormal, the physician should consider a referral to a GI specialist, and the patient should attend and get further workups such as ultrasounds, possibly genetic testing, blood work, and they like to track those bile acid levels. So I think with mine, we tested at 2 weeks, then 6 weeks, 3 months, 6 months, a year, and I still get yearly tests, unfortunately. They like to see the bile acids come down, and even if the bile acids come down, other liver enzymes such as alkaline phosphatase or AST or ALT may not come down right away either, and that can signify some liver damage has taken place, and they like to track it to make sure it's resolving. So this is our cool little workup for how you can follow your different bile acids. So if you're somebody with a bile acid of 6 and you're concerned, you can kind of follow the left side here where it's not technically diagnosable as ICP, but you should consider asking for follow-up and repeat bile acid levels, especially as your symptoms continue. And then they can repeat the lab work in 1 to 2 weeks and keep repeating it until the end of the pregnancy. If the testing continues to be normal, you can consider the diagnosis of ICP based on clinical symptoms, and you can try to plan that delivery around 37 weeks, 6 days or so, and the risks are less. You wouldn't be looking at an increased stillbirth risk and not necessarily a preterm delivery. If the bile acids are between 10 and 40, you'd be a little bit farther on the middle side, and the stillbirth risk, as I said, increases to 0.13%. They would prescribe you ursodiol. They'd be doing testing such as that ultrasound where you look at the baby and you make sure that the baby's doing all normal baby things in you. You'd consider earlier delivery, steroids if the delivery was prior to 37 weeks, and then you consider repeat bile acid testing after delivery as well. And then you can move all the way over to severe ICP, which is the levels of over 100. You'd still be getting ursodiol. Usually less relief is seen when you're given ursodiol over with the bile acids over 100. The delivery should be around 36 weeks at the latest. And then as far as the main points of this presentation, the diagnosis in the US is 10. So anything after 10, even a little in the high end of normal, is considered ICP. All cases need treatment with ursodiol and properly timed delivery. Bile acid testing is definitely more accurate in non-fasting state. So ideally don't fast before the test, or at least inform the physician if they mention to test. That there are some studies that show that fasting can lower the bile acids artificially. The risks are minimal for stillbirth, preterm delivery, and other complications if the bile acids remain low, but pregnancies with bile acids above 100 are considered more severe and need more aggressive management. And then you should always consider that once you've been diagnosed, you're always diagnosed, and delivery is going to be based on the highest ever bile acid level. So if you've had a level of 120 in a previous pregnancy, they're going to consider that when they decide when to deliver you. And then this is just a quick overview that I'm sure all of you know, but if you have symptoms like severe itching on the palms and the soles that start spreading inwards toward your body in the absence of a kind of a rash, that's probably the hallmark sign when people think of ICP. Extreme tiredness, fatigue, inability to sleep, usually because of the itching. You might have trouble with eating, weight loss during the pregnancy that's unexpected given that you're pregnant. You could have dark orange colored urine, problems with fat malabsorption. Your stools could smell greasy or kind of a bad oily smell. pain in the upper right of your belly that is right where your liver is. And then there's no other diseases that could explain the symptoms. That's where you might start thinking about ICP. Some risk factors, I think we mentioned the genetic predisposition, Scandinavia, South America, Southeast Asia, I think should also be on there. A prior diagnosis of ICP. I was told that the odds of getting ICP when it's over 100 is close, it's between 90 and 100%. I think if it's less than 99 or 90 or so, you're probably looking at 60 to 70% recurrence of ICP. As far as complications, you can have a higher association with preeclampsia, gestational diabetes, stillbirth, meconium aspiration, fetal distress, and of course, preterm birth, which could be based on the levels and necessary. And then it's very important to follow up with a liver specialist, especially in very severe cases, because you want to keep assessing and following that liver damage and continue surveillance in the future.
To let everybody know that we are going to continue to do community conversations on different topics and such. We'll have also guests. We're going to be having guests, also speakers and such. But I want to thank Laura so much and Lindsay for putting this all together and presenting. Thank you so much. Have a great one.